Okay, let's talk about this really cool case. This was a 20-something-year-old female who presented with a worsening headache for over a year. She said it was affecting her multiple days a week. She did not have a history of headaches prior to this. She characterizes it as throbbing and worse in the morning or when laying flat. She states her vision is slowly getting worse. She's tried Tylenol and ibuprofen without much relief. And prior to coming to the emergency department, she saw an ophthalmologist who said you need to go to the hospital and get an MRI and see a neurologist. So her medical history includes hypothyroidism, hypertension, sleep apnea, and morbid obesity. She does not smoke or drink, and her last menstrual period was a few months prior. She is irregular. On exam, her vital signs are stable. She's obese, but otherwise appears well and is pleasant and conversational. Her neuroexam is basically normal. Her cranial nerves are intact. Her upper and lower extremity exam is normal. Her gait is normal. Her visual acuity, visual fields, color vision are all full. She has no um, uh, afferent pupillary defect. In the ED, she gets a headache cocktail. She has some blood work, which is pretty much normal. She's got a very mild microcytic anemia. And neurology saw her, and they agree they're going to admit, obtain an MRI, and plan for a lumbar puncture for a presumed diagnosis of idiopathic intracranial hypertension. So let's talk about this. This is an illustration of how this is thought to occur. But basically, the problem is you have too much CSF and it's not absorbed correctly or drained correctly. So increased production, reduced drainage, increasing venous sinus pressure, or venous sinus stenosis increases venous sinus pressure, which is thought to contribute to reduced drainage. And then the obesity, female sex hormones, there's a predilection for obese young women. How does that work? It's not really known. Maybe it's the thoracic pressure. Maybe there's an inflammatory component. Maybe there's impaired lymphatic drainage. It's not really well understood. It used to be called pseudotumor cerebri. Typically presents with headache and blurred vision in obese young females. And the diagnosis is a combination of eye exam, MRI, and lumbar puncture. Initial treatment typically includes weight loss, acetazolamide, and potentially a ventriculoperitoneal shunt. Clinical presentation is a headache, which is very heterogeneous. It is often characterized as pressure-like. It is holocranial instead of hemicranial. It is frontal or retroorbital, worse on waking or with Valsalva-type maneuvers, which increase intracranial pressure, and typically improves with CSF removal, aka a therapeutic lumbar puncture. Patients can also have nausea, vomiting, phonophobia, tinnitus, back pain, and dizziness, and visual changes are obscurations and blurred vision. Diagnostic criteria include papilledema, normal neuroexam except potentially the cranial nerves, normal neuroimaging, elevated opening pressure with a normal composition of the cerebrospinal fluid. Here are some typical MRI findings, kind of going from A to D. This is a sella turcica, which is empty. Okay, there's distension of the optic nerve sheath, right? It is thickened. There is stenosis or hypoplastic transverse sinus here, which is going to contribute to impaired drainage in theory. And then you have flattening of the posterior globes on this axial cut here. Management, well, at least initially, again, is weight loss and acetazolamide. There are some other drugs that can be used, although less commonly. If that's not working, surgical options include an optic nerve sheath fenestration, dural venous sinus stenting, those are less common, and then CSF diversion, which is typically a ventriculoperitoneal or VP shunt. Bariatric surgery has demonstrated some benefit in case series, but has not been widely studied. Over here, there's a little bit of you're going down the diagnostic pathway. You start with weight loss or acetazolamide. If the headache symptoms are problematic, you have to think about other causes of headache and advise weight loss. If the vision loss or the symptoms are getting worse or rapidly worse, then you start thinking about surgical intervention, which is the VP shunt or the other two options. In the case of our patient, ophthalmology said she had bilateral optic nerve edema and disc margin blurring, which were consistent with IIH. Her opening pressure was 40, which is definitely elevated. Her MRI was normal except for flattening of the posterior globes, which you see on the right here. She was started on acetazolamide and discharged to follow-up with neurology as an outpatient. So 3 key points for IIH. One is that it's an idiopathic condition which is not well understood, but thought to occur due to impaired CSF absorption. Typically presents in obese young women presenting with progressive vision changes and headaches, and treatment involves some combination of acetazolamide, weight loss, and VP shunts, among other treatment considerations.